I'd like first to introduce myself and then my colleague. I'm Dr. المؤتمرالدولي from consultant medical oncologist, former faculty at King Abdulaziz University for medical oncology. Presently, I'm consultant medical oncologist and faculty at the King Saud University for Health Sciences in National and Princess Noor Oncology Center. Today in the afternoon, we'll be having our gastroenterology session dealing with the most important gastroenterological tumors in Saudi Arabia. My colleague is...
Let me just introduce myself also. I'm Professor Francis Yao. I'm currently the Medical Director of Fortis Colorectal Hospital and also a colorectal surgeon. So I think we can get started.
Yeah.
Okay. So today we want to introduce the first speaker, who is Dr. Takashi Sano, who is the Director of Gastroenterological Surgery at the Cancer Institute Hospital in Tokyo, Japan. Dr. Sano graduated from Faculty of Medicine in 1980 and completed surgical training at the same university, and he spent 15 months in Paris in 86 and 87. And then he worked at the National Cancer Center for 16 years. And he specializes in gastric cancer. And so, without much further ado, we want to call upon him to come and talk to us about treatment strategy for resectable gastric cancer. Dr. Sano.
Thank you. Good afternoon, ladies and gentlemen. Did you enjoy lunch? I did, although sometimes I was not sure what I was eating, but I enjoyed that very much. Thank you for this invitation. I'm very honored to be here. And I am a gastric surgeon, so today I'll talk about only the resectable gastric cancer, and some part may be overlapped with Professor Weaver's talk, but mainly from Japanese viewpoints. First, the gastric cancer is a disease with a wide variation, geographic variations. You see in the Eastern Asia and some part of Europe and South America has some high incidence, but in Saudi Arabia, I think it's one of the lowest incidence countries. And every year, about 1 million new cases arise, and 60% of them are from Eastern Asia, that is China, Japan, and Korea, and Mongolia. So in Japan, we have large high-volume centers. Mine, Cancer Institute Hospital, is the largest, and I'm now a senior surgeon. And for senior surgeons who have wide experience of gastric cancer, the small T1 disease is a piece of cake. It's too easy for us to do. Okay? Any surgeon can cure. Even endoscopists can remove that. So it's not our job. But when the tumor grows to T2 to T4A, invading the serosa with some limited lymph node metastasis, then this is the real surgical disease, and still it's easily resectable tumors for us. But it grows to invading the adjacent organs, or bulky or extensive lymph node metastasis, or when it invades the esophagus or the duodenum, well, it's resectable, but the prognosis may be difficult. So we call this marginally resectable gastric cancer. When it further grows, it's too late. It's not our job. And so, this is for medical oncologists. These are endoscopists. So in this talk, I'll concentrate on these easily resectable or marginally resectable gastric cancers. For resectable gastric cancer that may recur or that will recur, there are some strategy. Okay? It's the combination of surgery and chemotherapy or chemoradiotherapy. And there are various combinations: surgery followed by chemotherapy, or surgery followed by chemoradiotherapy, or chemotherapy first, followed by surgery with or without postoperative treatment, or chemoradiotherapy first, followed by surgery. So in order to discuss these combinations, we have to look back the randomized controlled trials of adjuvant or neoadjuvant chemotherapy in the world. For gastric cancer, there used to be numerous small-sized randomized controlled trials with inconclusive results. Okay. But now we have entered in the new era of adjuvant therapy for gastric cancer because we have 3 different modalities proven positive from 3 different regions. One is from the United States intergroup 0116 study. Postoperative chemoradiation was effective. Then from the Europe MAGIC study, pre- and postoperative 3-agent chemotherapy was effective. And finally, from Japan, it's ACTS-GC study, that is postoperative single-agent oral chemotherapy. And all these 3 trials were large-scale randomized controlled trial with surgery alone as a control arm. Okay? And all turned out to be positive and published in the New England Journal of Medicine in the early of this century. So everything has changed with these studies. Just let's look back briefly these studies. First was intergroup study 0116. They selected gastric cancer with curative resection and then randomized into observation or chemoradiation. And as you see, the chemoradiation showed a survival benefit, definite survival benefit. And recently, they published the long-term results of more than 10 years follow-up of this study. And again, they showed the survival benefit, overall survival or relapse-free survival even after 10 years. So chemoradiotherapy after American-style surgery for curative resection, this was very effective. And their subgroup analysis was very interesting. Okay? Look at this for males and females. This is the hazard ratio 1. So for male, it's a big benefit, but for female, no, not more. And D0, D1, D2. Okay, D0, D1 patients, that was good. Chemoradiation was better, but D2 not. And this histology, the tumors with intestinal type, very good benefit, but for diffuse type tumors, no. And altogether, women with diffuse type tumors, you must not consider chemoradiation. Okay, significantly worse. And the authors didn't discuss this a lot, but probably a couple of explanations would be possible. I guess that women with diffuse histology, they had lineage plastica type tumors and macroscopically resectable, but probably with already disseminated free cancer cells in the peritoneum. And of course, these nothing for the chemoradiation doesn't work for these. And in this study, the free cancer cells were not detected during the operation. Anyway, in this trial, we can say that for limited, 90% of patients underwent D0 or D1. After limited surgery, chemoradiation would be beneficial. The second trial is the MAGIC study from Europe. They selected gastric adenocarcinoma or lower esophageal adenocarcinoma, probably resectable, and then they randomized them into immediate surgery without any chemotherapy or perioperative chemotherapy. And the problem is that the preoperative diagnosis was not very strict, so in this group, nearly 30% of patients showed that the surgery was non-curative, so peritoneal disease and so on. So they turned out to be non-curative in 30% of patients. But still, anyway, the perioperative chemotherapy showed survival benefit. And then third study is the Japan ACTS-GC study. Okay? That was curative D2 gastrectomy with pathological stage 2 and 3 and intraoperative cytology, peritoneal cytology must have negative. And then we randomized them into observation or adjuvant S1 chemotherapy for a year. S1 is a new drug, prodrug of 5-FU and very active even for peritoneal disease. And we collected 1,000 patients and complete 5-year follow-up. This shows that the 10% 5-year survival benefit of only by this 5-FU oral 5-FU drug. So all these 3 trials, if you compare the same scale survival curves, MAGIC study, white line, this is the MAGIC surgery. This is intergroup surgery curves. MAGIC study was inferior because 30% of them was non-curative at the time of operation. But anyway, these chemoradiation were beneficial. And Japanese studies here, ACTS-GC surgery alone here, Japanese surgery alone was better than American chemoradiation. But I'm not saying that we are a good surgeon, but saying that I'd like to say that the Japanese trials, 90% of them had lymph node metastasis histologically, but still our patients were very fit and we selected carefully the good patients. Okay, the important point is in 3 different regions, the target population were different, but anyway, some adjuvant or neoadjuvant therapy showed that very similar power to increase the surgery alone survival. But nobody knows that whether this chemotherapy is beneficial for this population or this chemoradiation is beneficial for this ACTS-GC D2 section. Nobody knows. So it's not very sensible to compare these 3 or to look for which is the best. No. In each institution, for each population, these were positive. Okay. If you compare adjuvant or neoadjuvant policy, for example, in adjuvant settings, you can select patients very accurately because you have the pathological results already, and unnecessary chemo can be avoided because, if the patient showed only T2 tumor without lymph node metastasis, no chemo is necessary, and tumor volume is minimal or none. So in these settings, adjuvant is beneficial, but on the other hand, dose intensity is very high in neoadjuvant setting. In adjuvant, post-gastrectomy patients cannot tolerate well, and also we cannot evaluate the tumor, so the drug selection is blind, but in neoadjuvant setting we can evaluate the response. And so overall, the adjuvant policy is beneficial for rather early stage tumors, while neoadjuvant is beneficial for advanced stage tumors. So let's look back this picture for these easily resectable, marginally resectable, these conditions, easily resectable gastric cancers. Our policy is that surgery first. We do sufficient resection margin, D2 lymphadenectomy. Then, according to the pathological results, we may observe the patients without chemotherapy, or now in Japan we give S1, in Korea, Xelox turned out to be positive. Okay? And for this population, I think we should develop more effective adjuvant therapy, less invasive or less toxic. And we can identify high-risk cases by pathology, and we can give some different chemotherapy. But for marginally resectable, more advanced disease, multimodal therapy is mandatory. And I think that downsizing by neoadjuvant therapy is beneficial. And then we perform adequate surgery, then consolidate by adjuvant therapy. And for this population, we should develop sharp neoadjuvant therapy and establish optimal lymphadenectomy. Now, currently, these are the recruiting active randomized controlled trials of adjuvant or neoadjuvant setting. In Japan, now we are testing neoadjuvant for advanced disease. And in Europe, some preoperative ECC versus pre- and postoperative chemoradiotherapy, or perioperative ECX versus with or without bevacizumab. These are now currently active in Europe. And in Asian other countries, there are various kinds of combinations of chemotherapy. And in some French group, they are selecting signature cell carcinomas and trying some neoadjuvant chemotherapy study. But now, just let me think about lymphadenectomy for gastric cancer from surgeons' viewpoints. It was not Japanese, but a British surgeon who wrote 100 years ago that surgery of malignant disease is not the surgery of organs, it is the anatomy of the lymphatic system. Over the past 100 years now, what have we learned? In the West, surgeons learned many things from breast cancer, and so they know now that cancer is a systemic disease from the beginning, probably, and the role of surgery is limited, and lymphadenectomy is a staging rather than treatment. But in Japan, we have so many gastric cancer patients, and we have learned that cancer stays localized for a long time, waiting for surgeon's approach, and surgery always plays a key role, and lymphadenectomy is definitely a treatment. Okay? So with these experience, in the West, some surgery is now insufficient for some solid tumors, and in Japan, some surgery is too much, okay, for solid tumors. So we should change, or we should adjust according to the tumor biology. For gastric cancer, we have extensively studied the lymphatic flow, and we inject dyes in various parts of the stomach. There are definite, directions of flows. These never come up, always come down, and so on. There are some crossing channels gathering the celiac artery lymph nodes and so on. And we established this D2 lymphadenectomy technique. Now, this is the latest version of our guidelines. And when we perform total gastrectomy, if you remove all these blue nodes, this is D1. And blue plus orange area, D1 plus. And if you remove everything, it's D2. So these are simplified definitions of the new guideline. This is for total gastrectomy, and this is for distal subtotal gastrectomy. And now we are collecting the disease with these policies. And gastric cancer and colorectal cancer, or not rectal, but colon cancer are quite different. For example, colon cancer, if the cancer is here, lymph nodes are here, the operation is rather simple. You cut the artery at the origin and remove mesocolon and colon together with the lymph nodes. But the stomach has the pancreas, okay, or the spleen in the mesentery. So we should remove all these lymph nodes carefully, not injuring the pancreas. Or this is the pancreas, splenic artery, and the stomach, lesser curve, greater curve, and the lymph nodes. We should remove carefully, protecting the splenic artery and removing this bursectomy. And pancreas and spleen is always the problem. So in the obese patients, the technically very difficult operation. So gastrectomy is, for Japanese young, thin, fit patients, it's good, but it may be very difficult for Western patients. And even by Japanese experienced surgeons, BMI over 25 is an independent risk factor for surgical complications. Now, then the D2. The D2 is the gold standard in Japan for over the past 40 years. And in Japan, it had never tested against D1. Okay? In Taipei, they performed D1, D2 study. It's a single institutional study, and this is the only randomized trial which shows the benefit of D2 or D3. Okay? And in this study, they concluded that cancerous tissue can proliferate and grow from a few residual cells, or even one cell in lymph nodes that are not excised surgically. I was surprised with this, expression, or the fact that the Lancet Oncology accepted this. But anyway, they discussed this, and this is the only important study. And you know the Dutch D1, D2 trial, okay? They recently published the 15-year results. Over the past 15 years, they continued to say this is negative, negative, unfortunately. But finally, they showed that after autopsy results, D1 limited surgery showed cumulative continuous cancer recurrence or death, while other cause of death was much in D2, because D2 was very dangerous in that situation. And finally, with these results, they concluded that D2 lymphadenectomy is the recommended surgical approach for patients with resectable gastric cancer. And in ESMO clinical guidelines, they say D2 resection without splenectomy and pancreatectomy is recommended. And even in the American NCCN guidelines, they discuss that D2 recommended but not required. But anyway, the experienced surgeons in high-volume cancer centers should perform D2. Okay, so just let's go back to again these resectable gastric cancers. My conclusion is that T2 to T4 resectable gastric cancer should be treated with multimodal therapy. An adequate combination of surgery and chemo or chemoradiotherapy is the key of multimodal therapy. And selection of modalities, that is chemotherapy or chemoradiotherapy, adjuvant or neoadjuvant, it depends on not only tumor conditions but also the surgical circumstances. Thank you for your attention.
Thank you very much, Dr. Takashi, for your nice summary for the topic and clearly demonstrating the importance of D2 resection effect on the survival. We'll go for our next speak, which is the rectal surgical treatment in rectal cancer, and it would be given by Professor Donald Weaver. He is a professor and chairman of the Department of Surgery at Wayne State University. He has been chairman since 2005 and author of more than 100 scientific articles and book chapters. His main clinical interest is surgical oncology and minimally invasive surgery. He has been a visiting professor in many countries and is the associate director of international program at the Detroit Medical Center. We are lucky to have him here, and we'll go for his lecture.
Thank you, Mr. Chairman. They didn't tell me how to advance these slides here. Okay. Thank you very much. I'm pleased to be here, and I'm going to share with you a few ideas from a surgeon's perspective about the treatment of rectal cancer. I recognize that the audience does not have a lot of surgeons, so some of the slides which I had originally put in that deal with surgery, I think I'll pass over rather quickly, but try to give you some concepts about how rectal cancer is being managed today, and perhaps as importantly, along with Professor Gerard, who will speak on the radiation therapy for rectal cancer a little bit later, tried to leave you with the impression that this is a disease and the treatment of which is changing quite rapidly. First of all, just something which is obvious, and that is that rectal cancer and colon cancer, although we often lump them together and talk about colorectal disease, really from a surgeon's perspective are quite different problems. Rectal cancer is a disease where management of the sphincter is really of critical importance, and much of the surgical management of rectal cancer has to do with how the sphincters can be either preserved or not preserved. In addition to that, the routes of metastasis, just because of the anatomy of the rectum, are somewhat different from those that are seen in the colon. More than the colon even, multimodality therapy using The skills of the radiotherapist as well as the oncologist and the surgeon are certainly critical. And what is still in evolution, and I think is subject to a great deal of personal bias, is should rectal cancer be treated sort of adjuvantly, or is neoadjuvant a better therapy? Just again to remind you about the difference in the anatomy, if you look at the lower and mid-rectum, you see that there is a systemic opportunity for metastasis to occur, and this is an important determinant in both the evaluation of the patient as well as what may end up being treated. The evaluation of the patient, I think, from a surgeon's perspective is quite clear. It is critical for a surgeon to do the kind of examination necessary to make a judgment as to whether or not the patient is going to be able to have a procedure that will be able to save the sphincters. In that sense, not only the digital rectal exam, but some kind of colonoscopy or sigmoidoscopy done by the surgeon is really an important finding. There's no surgeon in this audience who has ever taken care of a patient with rectal cancer who has not been burned by the statement of a gastroenterologist that the rectal tumor was at a certain location, and when you went to operate on the patient, you found out it was really in quite a different location. And so it becomes really a critical piece to do, I think, for any colorectal surgeon, the endoscopy and the evaluation of this rectal tumor. For us, we also do the endoscopic ultrasound using an endoscopic probe. But as we've mentioned here as well, more even than in colon cancer, examination of the chest to make sure that you don't have pulmonary metastasis, and the markers, including the CEA, still continue to be, I think, a valuable test. So the factors that a surgeon needs to consider in management of rectal cancer are things which I think you would find to be obvious. Certainly the location, that is the distance from the anal verge until you reach the lower end of the rectum, becomes critical in making a judgment as to what kind of surgical procedure is possible. How much of the circumference of the rectum is involved is also an important point. What is the degree of obstruction potentially? Is it likely that this patient, if, for example, they're going to undergo neoadjuvant therapy, that they may get edema of the tumor to such an extent that they will develop a potential obstruction? And then, of course, trying to assess as best you can prior to surgery what the depth of invasion, what is the T status and the N status of the tumor is really, I think, critical pieces of information. Just to paint for you in the very broadest brushstrokes the overview of surgical procedures for rectal cancer, I think they can be divided functionally into three different types. Those which have to do with local excision, and I'll spend a little bit of time talking about that and about some of the changes which are occurring. The typical low anterior resection, which has been kind of the hallmark for upper and mid-rectal tumors, and then those patients who must undergo an abdominal perineal resection, an extirpative procedure which results in the complete removal of the rectum and a permanent colostomy. Local excision is usually used in patients who have a tumor which is fairly small and fairly low. Just taking those two pieces into consideration, generally for me, a transanal excision would be considered if the patient had a lesion that was either 5 centimeters below and perhaps less than 1/3 of the circumference of the rectum. Now, of course, there's many factors which influence that, and these are not immutable facts, but these are sort of some general guidelines which I think can be helpful. The transanal endoscopic microsurgery can be used for some small tumors, particularly sessile lesions which have malignant change, but generally are not considered it's not considered, at least in my mind, to be a commonly employed tool for invasive carcinomas. A transsacral excision, the approach through the coccyx with resection and a portion resection of the sacrum, can be a useful test a useful technique in some patients who have a midrectal tumor that otherwise would not be suitable for a transanal or for an abdominal perineal resection or for a transanal resection. And then there's a transsphincteric approach, which really, I think, very few people use anymore. It's a more of historical value where you can split the rectum, open the rectum, and remove it. And as I said, since it's not an audience of surgeons, I'll resist my temptation to try to teach you everything I know about how to do these kinds of procedures. So what is the role of local excision in the treatment of rectal cancer? I think that there possibly could be divided into sort of two groups. That is, people who have a fairly small rectal tumor and you believe you can remove that tumor in its entirety prior to any kind of therapy. This may be a suitable alternative for such patients. So the pre-therapy role for early stage tumors, and when coupled with appropriate postoperative radiation and or chemotherapy or both, this may be an appropriate role. It may be that there is a role in the post-neoadjuvant patient, and we're going to talk just a tiny bit about that. Perhaps others will talk about it a little bit more. But it's quite remarkable that a number of patients who have rectal tumors who undergo neoadjuvant radiation and chemotherapy will have a complete pathologic response. I'm going to talk about that for just a moment. And resecting or resecting the area where the tumor was to confirm histologically as best you can that there's not a mucosal residual, I think is potentially another indication for local excision. In addition to that, it may have a role in the future if we're able to better define histologically and with better imaging techniques what the perirectal lymph nodes are like. This just shows the transendoscopic microsurgical technique. This is the resectoscope. It has a binocular view. You can see 3 dimensions. It's like doing sort of laparoscopy through the rectum. There's an inflation technique. It's inserted through this technique. You can see that lesion. And you have instruments that allow you to do localized resection, and this can be done for very early stage tumors and can be quite effective. Low anterior resection, I think most of you know, is kind of the standard therapy for upper and mid-rectal lesions. This is a sphincter-sparing procedure. It can be done with or without a temporary colostomy, depending on the low nature of the anastomosis and what kind of anastomotic reconstruction you do. It may require a rectal J-pouch. There can be ultra-low techniques and so forth. But probably the most important thing from an oncologic point of view is that with the low anterior resection, as well as with the AP resection, the excision of the entire mesorectum is indicated in that this is the lymphatic and lymph-bearing areas. These procedures can be done laparoscopically. They can be done as open procedures. I think we're going to hear a lecture on robotic use and so forth. So I will, by courtesy, eliminate a lot of discussion about the surgical technique. So let me just go quickly through some of this. This is showing some of the surgical procedures. But I just wanted to mention a couple things about the low anterior resection and its reconstruction. How the low anterior tumor is, or the low anterior reconstruction is completed may have a great deal of influence on the continence of the patient and how well they're able to have a good quality of life as far as their bowel movement is concerned. there are some very important features about continence which colorectal surgeons know about and must be respected, both in terms of volume as well as in terms of angulation, in order to make sure that the patient has a functional outcome. Sphincter-sparing procedures, which most patients want, really need to be done in a way that allows a good quality of life, because if you have a poor outcome from a sphincter-preserving operation, it really is not as good as having a colostomy. Very few people come to the office of the surgeon with a rectal cancer and say, I really would like a colostomy. As a matter of fact, almost everybody says, please, doctor, do anything you can to prevent me from having a colostomy. And we certainly have many options, and we've discussed a few of them, and you'll hear others as well. But the truth is that sometimes the reconstruction, the results of all of the therapy will leave the patient without a colostomy, but with a function that's really not as good as a colostomy would be. And these include things such as stool frequency, difficulty with maintenance of continence, loss of compliance and volume of the rectum, a lot of perianal problems that can be associated, incomplete evacuations, and a lot of patients may have difficulty discriminating between whether they're passing stool or whether they're passing flatus. These, a variety of things have to all be taken into consideration in order to make sure that you give the patient the very best advice about whether a sphincter-sparing procedure would be valuable for them. There are some patients, as a matter of fact, in our own experience, about 8 out of 10 patients who maybe 15 years ago would have had a abdominal perineal resection can have some kind of sphincter-sparing procedures these days. However, there are some patients for whom, no matter what you try to do, no matter how good your neoadjuvant therapy is and how crafty you are as a surgeon, there are some patients who just simply cannot and should not have a sphincter-sparing procedure. And so these low-lying rectal cancers, which have an inability to get a clean margin, really should end up with an abdominal perineal resection and a permanent colostomy. There are, I think, an indication in some cases for patients to have a rectal stent. We use these now in 2 particular cases: those who have advanced disease with extensive liver metastasis or peritoneal disease, who have, by all estimations, a very limited life expectancy or a very poor quality of life, or who would end up being very high-risk patients to undergo surgery. These patients may be candidates to undergo rectal stenting. And the other is in the case of patients who may have a fairly bulky rectal tumor, but who have maybe some disease in the liver that's potentially resectable if they were to have response. These patients may undergo stenting and then bridge use that stent to bridge them to some kind of a rectal resection along with treatment of their liver metastasis. This just shows the 2 side by side. On the left side, you see quite a nice annular carcinoma of the rectum, and you can see this self-expanding stent on the left side, which may allow the patient, if there's proper management of the stent, and by that I mean proper management of their diet and so forth, that they may be able to have a functional bowel movement while they undergo some kind of neoadjuvant treatment in the hope of preserving the rectum in the future. These stents, although we use them a fair bit, do require a pretty significant amount of management. There's a lot of coaching that has to occur about how the patient should eat and things about their diet and the use of laxatives and so forth, which allow them to manage these stents properly. Because if you fail to do that, if you simply put the stent in and hope for the best, most likely the patient won't be doing very well. I'd just like to say a couple things about the adjuvant treatment of rectal cancer. And again, I'm not a radiotherapist or a chemotherapist, so again, these represent sort of a surgeon's perspective. Usually today, we manage patients who have apparently node-positive disease or T3 disease and higher, or people who have indeterminate lymphatic disease, perhaps an endoscopic ultrasound, which is suggestive of positive lymph nodes. Some patients, perhaps, who have a more malignant histological type, perhaps a signet cell type of a rectal carcinoma, or patients who have a close anal margin that we hope we might be able to change into a sphincter-sparing operation. These are the patients in general that we would offer adjuvant chemotherapy. Adjuvant chemotherapy. For the neoadjuvant chemotherapy, it's a little more of a controversial point. Partly, it's controversial because the studies are a little bit confusing. First of all, many of the studies that looked at neoadjuvant therapy were done in an era and reported prior to what we would now consider to be best therapy for rectal cancer, and that's prior to the era when we had FOLFOX, FOLFIRI, various kinds of other targeted therapies, Avastin, and so forth. And there's also a lot of controversy amongst surgeons about whether or not having neoadjuvant therapy, particularly neoadjuvant therapy that involves radiation, whether that does impair wound healing or not. The truth is, there's not very much data that's really convincing, and there's precious little prospective data, partially because in the place where it really would matter most, that is in really low tumors where you're trying to preserve the rectum, it's pretty hard to sell a patient on a study which says, let me draw a card, and if you get this card, I'm going to take your rectum out and give you a permanent colostomy, but if I draw this card, I'm going to give you chemotherapy and radiation therapy and try to save your rectum. And so the data is I would say spotty at best. But the real indication is to try to downstage tumors in order to try, if at all possible, to save the rectum. Probably the most influential study that looked at a large group of patients in a neoadjuvant setting was the German study that was reported in 2004. I would say prior to this study, at least in the United States, the majority of patients were treated with surgery followed by adjuvant radiation and chemotherapy. But since that study, patients who have more advanced local lesions or positive nodes have been subjected more and more, and I think now almost routinely for T3, T4, and those who have apparently positive nodes, to a neoadjuvant situation. And what we see is that there is a clear downstaging of tumors based on the neoadjuvant therapy. Of interest was that in that study, they had noted 194 patients, which, based on all of the sort of preoperative evaluation, the surgeon felt was highly likely to be able or would require an abdominal peritoneal resection. But after undergoing the neoadjuvant therapy, a number of patients, many patients, were able to be spared an abdominal peritoneal resection compared to those who did not undergo the neoadjuvant therapy. And so, really, the interest in reducing the number of abdominal peritoneal resections and the pretty solid data now that a number of patients, maybe as many as 20% of patients or so, can be downstaged to the point where they'll be able to have a sphincter-sparing procedure, drives now, I think, the most compelling argument for neoadjuvant therapy. Many other trials have looked at this whole subject of neoadjuvant therapy. I would say that just summarizing those, the incidence of local failure for advanced disease after neoadjuvant therapy is probably lower, that there are greater numbers, as we've already mentioned, who will avoid abdominal perineal resection and can be downstaged in order to have sphincter preserving operations. But the data for whether or not this causes a survival advantage, I would say, is at this point still fairly scanty. And so the present practice, I would say, for us in the neoadjuvant therapy is when we identify patients who have T3 or T4 disease, those who have a close distal margin, who really are very much hopeful that they can be downstaged and be turned into a sphincter-sparing operation, and those who have, based on either the MRI or the EUS, evidence of nodal disease, these are the patients who are presently in our system undergoing neoadjuvant therapy. Just maybe one additional comment about those patients who, having undergone neoadjuvant therapy, have what appears to be either a clinical complete remission, or in the case of those who undergo a complete resection are shown to have a pathologic complete remission. It's manifestly true that probably about 1 in 4 or 1 in 5 patients who undergoes neoadjuvant chemotherapy will have a pathologic complete remission based on data from resected specimens in patients who have undergone neoadjuvant therapy. The real question is what to do with these patients, and the present sort of standard of care is that resection should be done, that those patients should be resected. But there are emerging numbers of studies with dozens of patients which suggest that many of those patients never develop a recurrence of their local disease. And so it's pretty clear that as the future unfolds, I think we will be able to identify more and more certain patients who have excellent response to neoadjuvant therapy, who may not need extirpative surgery in order to be cured. How we're going to determine who those are, what kind of tests there's going to be, what kind of studies of the tumor, of the host, etc. I think these represent kind of some exciting opportunities for the future. I don't think we know the answers now. The present standard of therapy is to remove the tumor wherever, or the residual bed of the tumor wherever possible. But it's pretty clear that in the future there's probably going to be able to be identified certain groups of patients for whom particularly an abdominal perineal resection will not be required. So just in summary, I would say that rectal cancer, perhaps more than almost any other cancer in the GI tract, requires a multimodality therapy. The ingenuity and the skill of the surgeon, but not just the surgeon, the radiation therapist, the oncologist, these are all a critical, this association of these specialists is critical in the management of patients who have rectal cancer. Neoadjuvant therapy presently is widely being used for locally advanced and nodal positive disease, but the intriguing part is, as we mentioned a moment ago, that there are a large number of patients, perhaps 25% or so, who have pathologic complete remission with neoadjuvant therapy, and future studies which look at how to customize therapy, how to look at the host defenses, the biology of these tumors, may allow, I think, some patients in the future to be treated with less radical surgery. Thank you.
Thank you very much, Donald. Next, we have Professor Philip A. Philip, who will speak to us on neuroendocrine tumors, what's new in the treatment of this disease. Professor Philip is Director of Gastrointestinal and Neuroendocrine Oncology. He's also a Professor of Oncology at Wayne State University School of Medicine, Detroit, and the Karmanos Cancer Institute. He also serves as Vice President for Medical Affairs at this cancer center, and he is board certified in both internal medicine and medical oncology, and also is a fellow of the Royal College of Physicians in the UK. He has many accolades, and I think we won't take too much of his time to go through them, but to ask him to come and give us his thoughts and wisdom on this matter. Thank you very much.
Thank you for the kind introduction, and I'd like to thank the organizing committee and Dr. Mahmoud Shai for inviting me here. It's a pleasure to be here. This is my second time on this podium in the last 2 or 3 years, and I really enjoyed being here. Now, Dr. Weaver said something today about how we're trying to deal with cancers as a more chronic disease. And if I want to give an example in gastrointestinal cancers, I can't find a better one than neuroendocrine tumors. And this is also the reason why we got very much interested in it. And in our place in Detroit, we now have a GI and neuroendocrine service because we see the largest number of patients within the state of Michigan. And it's truly a very interesting and exciting area of GI oncology. And one of the reasons is that those patients, because they survive longer and sometimes much longer than the average person with GI cancer, then you accumulate more patients. So there's a increased prevalence of them. And those patients, over the years, when you manage them, you have to use the different modalities of treatment, which is really what I'm going to talk about today. So this is where we work. So the neuroendocrine tumors, as you well know, and I'm going to use the word expression neuroendocrine tumors to include the carcinoid, which are typically the ones we see from the midgut. So these are fairly widespread tumors. They can arise in multiple organs. They're not limited only to the gastrointestinal tract, although the commonest site is the midgut, and also including the pancreas. And you can see here that the gastrointestinal neuroendocrine tumors are the most prevalent compared, for example, to the lung and bronchus, and you can even see it in the gonads. But certainly in the digestive tract, these are the most common. And the ileum, as you know very well, in the small bowel, we see a lot of those malignancies. So the incidence is difficult to say really, but it varies between 3 to 6 per 100,000. And the increase has increased, as I'll show you in a second. And unfortunately, because the symptoms of those patients can be pretty non-specific many times, we diagnose them at a later stage. So it's not really uncommon for me to see patients who have been diagnosed by their internist to have irritable bowel disease for 5 years, 6 years, and then the diagnosis was made on a more advanced stage. Irritable bowel disease is something, for example, we see as a mistaken diagnosis, but it's not a mistake, it's just difficult to make a diagnosis. And if you look at the autopsy findings, there are more patients who have the disease, they're going to not die of it. Now remember, we're also doing a lot of CAT scans compared to 30, 40 years ago. And by doing a lot of CAT scans, you're also catching up with patients who have no asymptomatic disease, but they can have neuroendocrine tumors, like you're discovering more renal cell cancers with that. And you can see here that there's a dramatic increase, at least in the incidence of these diseases, partly maybe the diagnosis earlier or seeing them more often or thinking more about them. But also it could be that there's some biology behind it. There's something which is happening which is increasing the incidence. And if you look here, this is data from the United States. It's not really affecting one particular racial group. And again, I wonder if the same thing is happening in the kingdom here, where there is an increase in the incidence of these cancers, something I'd be interested to know. The subgroup of neuroendocrine tumors, the pancreatic neuroendocrine tumors, are also very interesting. This is a patient, for example, who has a mass there. A couple of months ago, Dr. Weaver sent me a patient with pancreatic mass. But you can tell from just looking at the patient that this guy does not have a pancreatic adenocarcinoma because you can feel the mass in the abdomen, yet the patient doesn't look ill. So these are typical patients who have a mass in the pancreas. They may or may not have metastases. They can have metastases, hypervascular, but certainly they don't look ill, and you can make a diagnosis even without a biopsy. And most patients are sporadic, but they can also be associated with certain genetic syndromes. And certainly their prognosis is much better than the adenocarcinomas in the pancreas. The pancreatic neuroendocrine tumors, most of them are non-functional, but some of them can be functional. And I have to say that in my day-to-day practice as an oncologist, not an endocrinologist, I really do not see much of these symptoms. Mostly I see the patients who have the non-functional tumors. Now, one of the most important things, one of the single most important things when you have a proper diagnosis and management of patients with neuroendocrine tumors is to have a pathologist who's going to be providing you with the grade of the tumor, the histological grade, because that's really very important. So the histological grade, well differentiated, low grade, intermediate grade, and then poorly differentiated, this is really very important for you. And if you see a patient and a diagnosis of neuroendocrine tumor and that's it, or a carcinoid tumor, that's really a very incomplete pathological report. In fact, it should also include other parameters to give you a feel for the grade of the tumor, such as the mitotic index and Ki-67, because this is really what's going to help you in terms of making treatment decisions and also assign a prognosis to the patient. A very important point. Why? Because if you look at the survival of patients, well-differentiated tumors, they can live for many years, whereas the poorly differentiated ones really do very badly, like the rest of the bad GI cancers. And this is important because what happens is that when I see patients who come to me from the community, I see problems both sides. I can see a patient who has a well-differentiated tumor who has been started on chemotherapy for no reason. I also see a patient who comes to me with higher grade tumor and the doctor has told the patient, oh, this is a neuroendocrine tumor, you can live many years, which is not true either. So really you have to give the right answer to the patient. For the surgeons, we have another issue here, which is most of our patients are presenting with more advanced disease, which means either they have regionally bulky disease or they have metastatic disease in the liver. So one of the things which we were having, I think, breakfast or lunch today, and the question was raised, if you have stage 4 colon cancer, do you remove the primary if the patient is not obstructed? Now, in our practice, in our institution, colon cancer stage 4, we do not remove the primary. But in this disease, in fact, there is more now a trend in the country, in the United States, to remove the primary because those patients survive long. And those patients, the primary tends to become very sclerotic and fibrotic, sending these roots into the mesentery, and they can get not only obstruction, but they can get bad obstruction where the surgeon can find it difficult to remove the tumor. So we are sending more and more of our patients who come with stage 4 disease and they have the primary to have the primary removed. And again, this extent of the disease varies determines the survival. Patients have metastatic disease, they don't do as well as patients who have localized disease, which we expect. So what are the treatment approaches for neuroendocrine tumors? Well, if it's a localized tumor, you catch it by chance. Someone has a terminal ileal disease, which comes with an obstruction. You open them up and you remove it. That's fine. Or a appendicular cancer, appendicular carcinoid, that's fine. But in patients who have metastatic disease, you have really a lot of options here. And this is what makes the management of these patients intriguing, because this is an ongoing process and the patients can be living for a long time. So debulking surgeries is something acceptable. Liver-directed therapies like radioembolization or TACE, systemic therapies, transplantation, radiotherapy, or watchful waiting. I've had several patients who come to me who have metastases in the liver, low burden, they're perfectly fine. And those patients, especially the ones who don't push for treatment, they don't want treatment, we just watch them for a while. Now, what are the things which really impact on the decision we make on how to treat those patients? The most important one is obviously the histological grade and tumor burden, but also the tempo or the pace of the disease. So if you're following the patient for 3 months, 6 months, 12 months. In patients whose disease is really moving very little, you really have a good possibility that you won't need to give them treatment for a long time. So that's an important part. Other factors are primary site. Pancreatic tumors can be a bit different in terms of their response to treatment to, for example, midgut tumors. That makes a difference. But also the patient preference. That's a very important point. Of the available systemic treatments, you're aware of the long-acting somatostatin analogs. Interferon, we always put it in our lectures, but I don't use it. We don't use it. It's very toxic. And then we talk about the other treatments. The cytotoxic drugs, generally speaking, pancreatic neuroendocrinoids can respond better than the midgut carcinoids, but again, we don't use them as an upfront treatment. Certainly in patients who come to us with high-grade, poorly differentiated tumors, those are the ones who we treat them like small cell. We give them platinum-based treatments upfront. These are the exception where chemotherapy is given. So the somatostatin receptors, which are present on these tumor cells, we use them. And one of the ways we target them is through using octreotide. And this is studied, the PROMID study, which is a long-acting octreotide given every 4 weeks intramuscularly versus placebo. This was in patients with well-differentiated midgut neuroendocrine tumors. Small study, but in this study it showed that giving those injections can slow down the disease progression. The time to progression is delayed. And this was the advantage of giving those injections. The response rate is almost zero, and survival difference is very difficult to show in those patients. But this has become more or less a standard we start off with in patients who come to us, who we'd like to give them treatment for the disease progressing, and this is one starting treatment we have, both in the midgut and pancreatic neuroendocrine tumors. But you have to remember that the patients who benefited from it were the ones who had lighter tumor burden. And also when the primary was resected, the outcome was better based on that study. And the benefit exists even if the patient doesn't have a carcinoid syndrome as such, has carcinoid tumor or neuroendocrine tumor, even if they don't have the syndrome, they will benefit from it. So shifting gears now to the target of target therapies, which is based on a mixing between the cloning of the gene, between our better understanding of the cell biology, the computing IT systems which help us to really deal with large volumes of data, and the war of cancer, which was declared 50, 60 years ago. So this has led to our new era of therapeutics, which is in target therapies. In neuroendocrine tumors, one target which has become attractive is the AKT pathway. The PI3 kinase AKT mTOR pathway. It has been shown in a very nice, elegant study I think it was in Science, that's an important pathway. And mTOR signaling, for that reason, has now become a target for using everolimus, which is the same drug you use in patients with renal cell cancer. We also now use it in patients with neuroendocrine tumors. So the mTOR pathway, which is downstream of the growth factor signaling. This is a study which was done by Jim Yao, which was the RADIANT-3 trial in patients with pancreatic neuroendocrine tumors. In this study, they tested everolimus versus placebo, and they showed a nice improvement in patients who received everolimus over placebo with a positive p-value. And based on this, the FDA has approved everolimus for patients with neuroendocrine tumors, and this has now become one of the drugs we use, especially after they fail the octreotide. Normally, we don't stop the octreotide LAR, we just add the everolimus to it. What about its use in the midgut carcinoids, midgut tumors, neuroendocrine tumors of the carcinoids? The RADIANT-2 trial was done in that respect, and although they showed that the progression-free survival was improved, so you can see that almost as a 5-month difference, but statistically it was considered to be not meeting their predefined boundary. So this study was deemed positive and negative. Negative in the sense that the company did not pursue the approval of the drug for this indication. However, in the United States, we are using everolimus in this setting in patients with midgut carcinoids who fail on octreotide, and we don't have much else to offer to them. The company now is doing RADIANT-4 to go back and do a cleaner study in this group of patients, and we don't have results, obviously, at this time. At the Southwest Oncology Group, where I I practice, we're planning to do a study using a drug called BKM120, which is from Novartis, which is a pan-PI3 kinase inhibitor. So this is a trial which we may take off the ground over the next few months. Now, the other interesting thing about these tumors are they are very vascular, they're hypervascular, and hypervascularity can be, again, a target nowadays with several of the drugs we have in terms of targeting the VEGF, VEGFR. And one study, which was the sunitinib versus placebo in patients with, again, neuroendocrine tumors of the pancreas, that was completed and published. And this study showed that sunitinib can also have a benefit in those patients with a progression-free survival prolongation compared to placebo. So sunitinib was also approved as another option in patients for neuroendocrine tumors. It is approved by the FDA. There is another study looking at bevacizumab, which is an anti-VEGF drug, combining it with everolimus. This is a study which I think is just completed, and we're waiting for the results. And at the Southwest Oncology Group, Jim Yao, who's the most active guy doing neuroendocrine tumors in the United States, has another study which was bevacizumab octreotide versus interferon octreotide. This study has completed accrual, and we're waiting for the results, which ultimately will tell us whether bevacizumab has any role to play in this disease. There are a number of other drugs that are really in the process of being tested. I'm going to say a few words about the octreotide somatostatin receptor targeting, and there are a number of other drugs. BK120 I mentioned to you, pazopanib, cabozantinib, bevacizumab is being tested, and also the combination of chemotherapy, capecitabine plus temozolomide. So a number of other agents are currently actively being treated. I just want to say a few words about the peptide receptor radionuclide therapy with radiolabeled somatostatin analogs. At this point in time in the United States, really we don't have much in the way of this therapy. In fact, we're just starting to have it in few centers more as an experimental treatment. And in fact, a number of our patients will travel to Europe to get this treatment. So the lutetium-based and the Y90-based are taking place. The indium-111 really is not as interesting because it's not a beta emitter, and these basically you're targeting the somatostatin receptor using a somatostatin analog linked to a radionuclide. And therefore, patients who are having an octreo scan, which measures the activity of the nucleotide in terms of the receptor, and patients who have positive scans can benefit from this. And we see partial responses in a fair number of patients and a good duration of response. And again, it works better if you have a small tumor burden. So this treatment, which is being in Europe for a number of years, is just catching on in the United States. For some reason, we couldn't get the FDA to get this treatment. This is an example of a study done in Europe using the Y90 and over 1,000 patients, response rate of 34%. But however, in the earlier studies, there was problem with the renal toxicity, which is now being less of a problem. Now, what about hepatic transarterial therapies? As you know, these tumors, one of the areas that they like to metastasize is the liver, and in the liver they can be very hypervascular, and for that reason, it makes sense to try to do liver-directed therapy into the hepatic artery. And you can do any type of embolization, transarterial chemoembolization, you can do embolization, bland embolization. Trying to ablate these lesions is not very popular, at least where I work, because those tumors can affect the liver very diffusely, and therefore a treatment through the hepatic artery makes more sense. You see how hypervascular they are. And in our institution, we really, when we do hepatic arterial therapy, whether for carcinoid or for endocrine tumors or for colorectal tumors, we tend to do nowadays much more using the Y90 in terms of the radioembolization rather than chemoembolization. This is one study from the group by Riyad Salem from Northwestern, and they show that you can see some interesting results with complete response and partial response. But it takes a while for you to see the effect of the treatment. So trying to do a scan a week after the treatment isn't really going to help you that much. We do a right side, and then we do a left side, and then we will follow the patient. And there are some side effects, but usually they are very easily reversible. So this is a treatment that we do use a lot in patients. For example, in patients who are on octreotide and the disease is progressing and it's only in the liver. So this is one option to use in those patients. Now, what about liver transplantation? The short answer is it's not a standard of care unless you're Steve Jobs. So this is one study that was done, and you can see some interesting results. But based on one study from a single center, selected patients, I can't tell you if this is ever going to be a standard of care. But certainly, in some patients, it may make sense if they have disease confined to the liver for a long time, and therefore liver transplantation may be in future something which may be used more often. But at this point in time, it's not something which it is recommended. Finally, we talked about multidisciplinary care earlier on about rectal cancer and also gastric cancer. In this disease, it becomes even more important to have a good multidisciplinary team. Those are patients who are otherwise mostly healthy, but they come with problems. They're similar to your breast cancer patients who come every week, every 2 weeks, every month, every 2 months, 3 months. They need someone to talk to them. They need multidisciplinary care. So surgery, oncology, pathology, nuclear medicine, endocrinology, interventional radiology. It's a great program to have because these are patients whose management can be also very rewarding and good experience. So to summarize, there is an increasing incidence of these tumors, so it's an important disease to keep in mind, and I think it was worth giving a talk about it today because this is something which we will be seeing more and more of those patients. There are some pathways that are of interest, PI3 kinase, VEGFR, but we're looking obviously for other pathways also. The treatment is highly personalized. This is not your common variety colon cancer. If you have surgery, you get adjuvant chemo. If you have a metastatic disease, you have chemotherapy, combination chemo. Here, you can go in different directions depending on where the patient is, pathology, histology, tumor burden, what the patient wants, what the patient does not want, and all these things. And therefore, we believe that the management must be by a multidisciplinary team that really has a very good experience in the management of these tumors. Now, I can tell you again from my experience, because being a tertiary major cancer center, we see a lot of patients coming to us from the community where they have lesser exposure, lesser experience, and you can see people truly receiving treatments or not getting treatments that they should be getting, and it would be nice to have a nice core group, and I would encourage probably for the institution here at King Abdulaziz to have to develop a special interest that can be a regional or even a national center for these diseases that are not common but increasing in incidence, but also prevalence is going to increase much more because those patients will be surviving longer and longer. And thank you very much.
Thanks, Felix, for the nice, comprehensive, quick review for the topic. We're going to move to the next talk about adjuvant therapy for colorectal cancer. Should all patients be treated? It's going to be presented by my longtime colleague, Dr. Shawki Bazarbashi, who did the head section of medical oncology at King Faisal Specialist Hospital. He had been trained in Wayne State University and got his American board in the medical oncology more than 2 decades ago. And he is currently the head of the section, and he had multiple publications in the field. And his main interest is GI and GU tumors. So, Shawki.
Thank you, Mr. Chairman. I want to thank the organizing committee for inviting me, and I want to apologize because I do have a bad cold, so I hope you'll be able to understand me. The reason behind talking about adjuvant therapy in colon cancer is basically what you see on the right-hand side, which is the 5-year survival of patient with resected colon cancer. And as you could see, the 5-year survival depends on the stage of the patient. However, unfortunately, this is not a very good system. We have not reached a perfect system yet, because you could see, for example, a patient who have stage 2C have a 5-year survival of 45%, while those who are stage 3, A and B, have a better 5-year survival. So I think this still has to be refined, maybe possibly with more molecular markers. And I thought my talk is actually is going to be after lunch, and people will be, the flow of the blood usually after lunch goes to the stomach rather than the brain. So what I thought I'll do, if I can keep you awake for about just 5 minutes only, and I'll make the points first initially. I'll put my summary first, and then I'll discuss with you the details. So the summary of my talk says is adjuvant chemotherapy with FOLFOX or Xelox gives the best 5-year survival or best survival in patients with the stage 3 colon cancer. We also, I will show you that patients who are elderly, more than 70 years of age, probably do not benefit from adding oxaliplatin to their adjuvant therapy or to the fluoropyrimidine. Also, I will show you data to show that delay in administering chemotherapy, which is after a month usually, will result in about a reduction in the efficacy in the chemotherapy by about 10% every month. I'll show you that irinotecan-based regimens are not effective in the adjuvant therapy, and also we'll discuss the controversies in the stage 2 colon cancer. And also, I will show you that oxaliplatin does not add benefit to the adjuvant chemo in patients with the stage 2 colon cancer. Also, we will touch on some molecular markers. Some of them are prognostics, and some of them are predictive, but none of them is yet standard. The one that is most probably will be in use in the near future is the microsatellite instability and the SMAD4. Also, I think I did not put the data for this one. Much more recently, there has been data to show that dietary glycemic load during and after adjuvant chemotherapy does increase the risk of recurrence. So if your patient asks you, doctor, what do you suggest I eat? I think you should tell him you should not eat too much carbohydrates. Okay, so adjuvant therapy started in the early 1990s when initially 5-FU levamisole became standard, and it remained standard up until 1996 when 6 months of 5-FU leucovorin were found to be as equal as to 12 months of 5-FU levamisole. In 2004, FOLFOX became the standard of care after the Mosaic trial. At the same time, we were able to find out that oral fluoropyrimidine are as good as IV fluoropyrimidine. And also, just about 1 year later, we were also able to find out that adding oxaliplatin not only to infusional regimen, but even to bolus regimen, like the FLOX, which was done in the US, also improves survival in patients with stage 3 colon cancer. In 2009, there was more disappointing data that adding Avastin to the chemotherapy does not improve survival. And in 2010, we had more disappointing data that adding the second targeted agent, which is cetuximab, does not actually improve survival in patients with colon cancer. So if we are to examine the data, those are the data that shows oral fluoropyrimidine are as good as IV fluoropyrimidine. 2 trials looked at, one of them looked at capecitabine, the other one looked at UFT with the folinic acid. There was minor differences in those trials. In the exact, it was only stage 3. In the NSABP, it was stage 2 and 3. In the exact, the primary endpoint was disease-free survival. In the NSABP, it was overall survival. Regardless, both trials were positive. They showed equal efficacy for the oral fluoropyrimidine as compared to the IV. Here, capecitabine is as good as 5-FU leucovorin, and that was also better tolerated. As you can see here, the side effects from capecitabine, which is the yellow bars, are less than the one in the blue bar, which is 5-FU-leucovorin. The only side effect, which is more with the capecitabine, is the hand and foot syndrome. This is the data also for the UFT, and basically shows that UFT is as good as 5-FU and leucovorin. Then the Mosaic trial in 2004 was presented, and the Mosaic trial actually studied adding oxaliplatin to infusion of 5-FU-leucovorin. The standard arm that was the Degramo regimen, LV5-FU2. The investigation arm was the FOLFOX4. It accrued patients who are stage 2 and stage 3, and did not take patients more than 75 years of age. The primary endpoint of this trial was the 3-year disease-free survival. And that was based on data that was actually pioneered by Dan Sargent from the Mayo Clinic. Dan have shown that if you look at the disease-free survival in patients with colon cancer at 2 years or 3 years, it's as good as looking at survival. So disease-free survival is a surrogate endpoint for overall survival at 5 to 6 years. And as you can see, this is from 6 different trials. The interesting things is patients who recur in stage 3 colon cancer, they recur, most of them, 80% of the recurrence do occur in the first 2 years or 3 years after surgery. And accordingly, you see there is a very nice correlation between the 2 years disease-free survival and the 5-year overall survival for stage 3 patients. And this is, there's also a very nice correlation between disease-free survival and for stage 3 between 2 years disease-free and 6 years overall survival. So very nice correlation between 2 years or 3 years and 5 years or 6 years overall survival. So this is the Mosaic trial, and the Mosaic trial, for those who don't know what's FOLFOX, FOLFOX is actually, as I said, infusional chemotherapy, initially oxaliplatin followed by 2 days of infusion of 5-FU and leucovorin. And this is the basic FOLFOX6 that we use instead of FOLFOX4 for most of the time. So the trial met its primary endpoint. There was a statistical improvement in disease-free survival for the patient who received the FOLFOX as compared to LV5-FU2. And if you look at patients who are stage 2 and stage 3, the difference for stage 2 was 3.8%. That's the absolute difference. For stage 3 was 7.5%. This difference was significant in stage 3, but not significant in stage 2. If you look at the overall, if you look at high-risk patient, there was a 7.2% difference, high-risk stage 2 patient, 7.2 absolute difference in disease-free survival, but unfortunately this did not translate into statistical significance, most probably because of the numbers. So the whole group, stage 2 or 3, overall survival was not significantly different, only 2.6, but when they looked at each subgroup, stage 2, there was no difference in overall survival. Stage 3, there was an absolute difference of 4.4% that was statistically significant. That made FOLFOX the standard of care for patients with stage 3 colon cancer. That was at the expense of some toxicity. The one that is most notable is the neurotoxicity and more, of course, neutropenia, as with leucovorin 5-FU, LV5-FU2. And interestingly, some of this toxicity can actually last for a long time. So this is the neuropathy in the trial, and you can see up to 5 years or 4 years, there are patients who still have some toxicity. And those of us who have treated those patients will realize that patients continue to complain of the toxicity. So the second trial that actually looked at oxaliplatin is the NSABP CO7, and that looked at a bolus 5-FU, which 5-FU leucovorin, versus the flux regimen, which is a bolus 5-FU leucovorin and oxaliplatin. It accrued stage 2 or 3 patients, and there was a large number of patients, about 2,500. And the primary endpoint was 3 years disease-free survival. The trial met its primary endpoint. There was an improvement in the survival, both 2 and 3, and the hazard ratio was 8. The infusion, also oral chemotherapy, when you actually combine it with oxaliplatin, you get an improvement in the disease-free survival. This is the Zeloxa trial that actually examined adding oxaliplatin to an oral fluoropyrimidine, which is Zeloda, and only in stage 3 patients. And the comparative arm was the standard Mayo Clinic or Roswell Park regimen. The primary endpoint was disease-free survival. The trial met its primary endpoint. As a matter of fact, if you look at the difference, it became even more and more as we go in terms of disease-free survival. This was statistically significant. When the trial was published, there was no difference in overall survival. However, there was an updated publication at an 83 months follow-up that showed an improvement in the overall survival that was statistically significant. At 7 years, Zelox 73, while 5-fluorocovorin 67, that was statistically significant for overall survival. Well, 3 trials looked at adding irinotecan to different types of, or different regimens of 5-fluorocovorin, and unfortunately, none of those 3 trials was positive. You have the CALGB trial, you have the CORD trial, and they have the PTAC trial. Accrued large number of patients. None of them actually had any positive result, and that kind of was the end of using irinotecan in patients with stage 3 colon cancer. Now the story in patients with stage 2 is slightly different. Most of the stage 2 were included in the stage 3 studies, and unfortunately, the data has been very conflicting. We have data from the US, we have data from Europe. The US data were positive for survival for chemotherapy in stage 2 cancer, while the European data were negative. If I show you this is the impact meta-analysis, which is mostly European, 1 Canadian trial and 2 European trial, that actually accrued good number of patients, as you could see, and you could see that those trials did include patients with stage 2 and stage 3. However, negative nodes were a little bit more than 50% in all of those 3 trials. And as you could see, in stage 2, there was no difference between the control and the treatment arm, while in stage 3 that was statistically different. So at least the European trials did not show any superiority for chemotherapy. The American side, the NSABP, looked at the chemotherapy versus no chemotherapy, and as a matter of fact, if you look at the trials themselves, they are very strange. First of all, you have very different type of chemotherapy. You have here protracted venous infusion, and here those 2 trials actually comparing chemo with chemo, so they are not like chemo with control. Yet in Dukes B or node negative, there was an improvement in death or survival, an improvement in recurrence. And when they put them all together, the difference in survival for stage 2 and stage 3 were nearly the same for stage 2 and stage 3. So there was an improvement in both disease-free survival and overall survival. So Japanese data even made things more complicated. The Japanese data, the benefit was even more for a patient who had node negative as compared to node positive, as you could see. So one large trial, which is the Quasar trial, I think it answered some of the question of stage 2. Unfortunately, it was not directed to stage 2 patients. It was in patients who with an uncertain indication. This is a British trial, randomized patient to 5-FU plus leucovorin plus or minus levamisole versus observation. However, 92% of those patients were actually node negative, and the trial showed that yes, chemotherapy does improve survival in patients with the stage 2. However, this difference is really small. So you have somewhere around 3% improvement in overall survival. At the present time, ASCO recommendation is that we don't use routine adjuvant chemotherapy for patient with stage 2. However, there are certain subset of patients, those with the high-risk group, based on previous data, that might benefit from adjuvant chemotherapy. So the question is, should oxaliplatin, if you are going to use chemotherapy in patient with the stage 2, should you use only fluoropyrimidine, or should you use Folfox or Xelox? And I think the data that we have says there is no convincing evidence that you should add oxaliplatin, and fluoropyrimidine is enough. This is an analysis that was done from 4 trials presented 2 years ago, basically looking at 4 different trials and basically showing that there was no difference in overall survival if you use oxaliplatin or no oxaliplatin, and no difference in disease-free survival if you use oxaliplatin versus no oxaliplatin. So there is no statistical difference. Even if you look at high-risk patient, if you want to treat high-risk patient, the data is not convincing enough. There is an improvement in the overall survival and disease-free, but this did not reach statistical significance. So what you should do is you should treat those patients with fluoropyrimidine alone. So the story of biologics, I told you that the data unfortunately was very disappointing. The NSABP C08 examined adding bevacizumab to Folfox chemotherapy. Bevacizumab was given for 1 year, although the chemotherapy was given for 6 months, and that was in stage 3 colon cancer. The primary endpoint was disease-free survival. The trial did not meet its primary endpoint. It was a negative trial. This is the AVANT trial. It had 3 arms. The standard arm was Folfox 4. The investigational arm was Folfox 4 plus Bev or Xelox plus Bev. Also, this trial did not actually, it was a negative trial. There was no improvement in the disease-free survival, and there was negative improvement in overall survival. The other negative trial was adding cetuximab to chemotherapy, and the NO147 trial examined adding cetuximab to Folfox. Of course, when the trial was started, the story of KRAS was not known. The trial was amended later on to include only patients who are KRAS wild type, and they were randomized to Folfox versus Folfox plus cetuximab, and that was in patients with the stage 3, and the primary endpoint was disease-free survival, and the trial did not meet its primary endpoint. So it was a negative trial. Okay, so do we have any predictive markers for patients with the stage 2 or 3 colon cancer? Well, the ones that everybody know about is the microsatellite instability. And for those of you who are not aware what is the microsatellite instability, you know there's, when the DNA is formed, there are sometimes mistakes, and there is a mismatch in some of the genes, like the C here should be attached with a G, but if it comes with a T, then it has to be repaired. And the repairing system in the body, there's 2 enzymes. There is a excision repair gene that actually will excise the part that is wrong, and then there is another enzyme that will redo the whole thing. This is called a mismatch repair process. And when we examine the colon cancer cells, we know that some of those cancers do have deficiency in this process. We call them deficient mismatch repair gene, and some of those, the process is very well done, and we call it proficient mismatch repair. So those which are deficient are microsatellite unstable or microsatellite unstable high, and those are who proficient is microsatellite stable or microsatellite unstable low. So what we know is, and this is from data from Dan Sargent from large randomized trial. He looked retrospectively at patients who actually were in randomized trial given chemotherapy in the adjuvant setting. Regardless of whether the patient receives chemo or not, patients with the microsatellite instability had a better survival than those with patients who have microsatellite stable tumors. However, if you look at patients who actually received chemotherapy, fluoropyrimidine, you will see that there is no difference in those who actually had chemotherapy versus no chemotherapy if they have deficient or unstable microsatellite. So the story even gets worse. If you look at stage 2 colon cancer, those who receive chemotherapy and they are microsatellite unstable, the chemotherapy patients do worse, while in patients who are 3, there is actually no difference in their survival whether they're given chemotherapy or not. And those are patients with microsatellite instability or deficient mismatch repair system. Now, however, if you have a proficient microsatellite system, so in stage 2, you give chemotherapy, no difference. In stage 3, yes, they do have benefit from chemotherapy. So the other factor that we know that actually of prognostic importance is the gene on 18q when there is loss of homozygosity. Or what happens is one of the allele gets lost. So in those patients, they have a poor prognosis. You look at this patients who had the same patient who had chemotherapy versus no chemotherapy, and of course, patient chemotherapy with stage 3, they do better. However, if you evaluate them, you see those who actually received chemotherapy, if they have microsatellite stability and they have loss of heterozygosity, they do better than those. If they don't have the loss of heterozygosity, they do better than those who do have the loss, both in disease-free survival and overall survival. So 18q loss of heterozygosity is actually a poor prognostic index. One other thing is genetic signature. Now we do have a kit, just like the kit you have for MammaPrint or Oncotype DX, and there are 7 genes that actually, for recurrence, the total genes in this kit is about 18 genes, and it gives you a percentage or likelihood of recurrence. This has been tested, validated on the Quasar trial. It divides the patient into 3 groups: low, intermediate, or high risk of recurrence. If you look at the different biomarkers that we know now in colon cancer, stage 2 and 3, there are 5 biomarkers. You have the microsatellite stability, or you have the SMAD4, you have loss of heterozygosity of 18q, KRAS, and BRAF. And we know now this group did the multivariate analysis on which of those is actually the most important. They looked at both clinical parameters and molecular, and found that both the microsatellite instability and the SMAD4 had the highest prognostic importance. As a matter of fact, you look at this group of patients who had stage T3 and 1, and if you actually examine them in terms of the microsatellite instability and the SMAD4, you find that those who are microsatellite unstable high plus SMAD4, there's loss of expression. Those T3 and 1, they do even better than T3 and 0. So I think molecular markers will be an important actually part of our staging system in the near future. One last thing is, does oxaliplatin or should oxaliplatin be given to patients who are elderly? 2 trials that examined this found it doesn't really add a benefit. This is the Zeloxa trial. Patients with who received Zelox, their 3-year disease-free survival was 71 as compared to 67 for 5-fluorocovarin. If you look at the hazard ratio was 0.80. If you look at the hazard ratio for the group less than 70, it was 0.79. For more than 70, 0.87. That was not statistically significant. Believe it or not, the trial, the analysis here was supposed to be positive, and that's how it was presented. And I see it negative. The same thing in the Mosaic trial, patient between 70 and 75, the hazard ratio for those patients was 0.93, so there was no statistical significance for both the disease-free survival and overall survival for patients who are 70 to 75. The Mosaic, as I said, did not include patients who are more than 75. Last is the delay in giving chemotherapy, and this is something that I found it very interesting. We commonly have patients who come to us after 3 months of having surgery. We don't know what to do. And this is a systematic review that looked at what does delay in chemotherapy do for the efficacy of chemotherapy. Many trials that was pulled together, and the numbers is, by the way, the numbers are actually the references, so you don't need to look at the number. What you need to look at here, this is the hazard ratio of 1. This, the length of the line is the delay, how many weeks, and this axis is the actually hazard ratio. So you could see that there is, if you take the consensus, there is an increase in the hazard ratio of recurrence the more delay the patient is from the chemotherapy. And if you actually, they put this in a forest plot, and you could see a delay by 4 weeks will actually have an overall of about 1.14 delay. So it's about 14% or 10%. So I already gave you my conclusion up front. I don't need to repeat it, but I'm willing to answer any question. Thank you for your listening.
Thank you very much. Next, we have a presentation on the radiotherapy and its use in rectal cancer by Professor Jean-Pierre Girard. Professor Jean-Pierre graduated as a specialist in radiation oncology in 1973, working with Papillon in Central Lyon, Girard until 1979, when he was made professor of the University of Lyon and became head of radiation oncology at the same hospital. And he is today still very active in his main field of interest, which is conservative treatment of rectal cancer, randomized trials, and development of contact X-ray brachytherapy, design of the new Papillon 50 kV system, new applicators and rectoscopes. And we look forward to hearing his lecture now. Thank you very much.
Well, thank you, Mr. Chairman. As you said, I've been working in Lyon for more than 30 years, where I made some randomized training, and now I'm in Nice, and I understand that the Corniche in Jeddah in a few months will look as great as it is in Nice under the sun. You know my disclosure. I've been working with this machine for more than 40 years, and now I am involved in the design and experiment of this one. Rectal cancer, no problem. I fully agree with what Dr. Weber said just before in his excellent talk. Surgery is the main treatment. And of course, we should perform TME surgery and local excision in some cases. And when we want to see if there is some benefit from any treatment in association with surgery, only randomized trial gives some evidence. Another point which was made very clear by Dr. Weber, that clinical approach in rectal cancer, not in colon cancer, but in rectal cancer, is a key point. And digital examination and endoscopy, I will demonstrate how much it is important to achieve conservative treatment. And of course, as in all the field of cancer, we must work together. What is the benefit of neoadjuvant radiotherapy? We have heard, and it is definitely proven, that now the local control in T2, T3 is 95%. It is not anymore an issue in T2, T3, still in T4 sometimes. Conservative treatment. You will see that, in fact, there is no or little influence of this neoadjuvant treatment, and if we have improved, it is mainly because surgical techniques and concepts have improved and evolved since the past 20 years. And I would like to stress the importance of clinical complete response to achieve organ rectal preservation, a bit like we achieve in anal canal carcinoma. I wrote this paper some years ago, if Europe was right, because at that time it was recommended United States to do post-operative chemoradiotherapy, and that it has been said, this German trial was a pivotal trial to demonstrate that preoperative radiotherapy was better tolerated and slightly more efficient than post-op chemoradiotherapy. And at the same time, in Netherlands, they made a beautiful trial where they said that even with a TME surgery, preoperative radiotherapy was decreasing the risk of local relapse. And in France, we demonstrate that chemoradiotherapy, in terms of local relapse, was more efficient than radiotherapy alone. In 2005, the question was how to optimize this chemoradiotherapy protocol. I will speak of two trials, a very scientific trial, STAR trial in Italy, where they give the 5FU radiotherapy and they test addition of oxaliplatin. And in the same patient, 600 patients, the Accord 12 trial, where we use capecitabine instead of 5FU, and we increase the dose from 45 to 50 gray in 5 weeks, 15% biological increase, and we also add oxaliplatin. In this Accord 12 trial, we were successful to accrue cells of 600 patients in less than 3 years, and it was mainly T3 patients, some T2, some T4. And the result being published 2 years ago shows that there was more toxicity with the Kpox 50. There was no difference in anterior resection. Post-operative death, when I started rectal cancer 40 years ago, it was close to 10%. Now, nobody cares, is my patient going to leave the hospital? They always leave the hospital. That disappeared, the post-operative death, exceptional. Then when you look at the main criteria endpoints, sterilization, it was borderline significant, but if we accumulate no visible cell and few residual cell, this Kpox 50 had an increased efficacy on the obtained specimen. And if we look at the circumferential margin defined as less than 2 millimeter, not 2 millimeter, there was also a significant benefit from the Kpox 50 regimen. And if we compare this Accord 12 trial with the STAR trial, we see that the toxicity in the STAR trial, where there was only the addition of oxaliplatin, was 7%, was 24%. And obviously it is the oxaliplatin which gives the toxicity. And here we can assume that it is the oxaliplatin and not the 50 gray which gives the toxicity. Sterilization rate, no difference when adding oxaliplatin. Oxaliplatin is not efficient in addition with 5FU. And here with the 50 gray, 13%, 90%, the benefit is coming from the dose escalation of radiotherapy. No difference in circumferential margin, a small reduction with the 50 gray. But none of these trials show any difference in sphincter saving rate. And our present conclusion is that oxaliplatin increased toxicity, mainly diarrhea, when added to chemotherapy and radiotherapy without impact on sterilization. It is not a good radiosensitizer. 50 gray 5 weeks is compatible with surgery and increased sterilization rate. Circumferential rectal margin, there is a clear radiation dose effect. And capecitabine has the same activity as 5FU. And you know that in the United States there is a large trial, NSABP 504, which is close from this conclusion. And we have recently published the result at 3 years of this Accord 12 trial. With the Kpox 50, we are now less than 5% of local relapse, and we have no toxicity, but there is no difference, as it was said, on overall survival rate. So at the present time, our standard treatment is preoperative CAP 50 with radiotherapy 50 gray, 2 gray per fraction, and capecitabine on radiotherapy days, because we think there is a radiation dose effect, and we stress the fact that we should irradiate small volume. it has been clearly demonstrated in the Dutch trial that 95% of the local relapse in rectal cancer are below the S2, S3 interface. And it is detrimental and inefficient to irradiate above this limit in most of the cases. This is a cancer of the middle rectum, quite big. This is the anal canal, you can contour this, and this is the limit of the treated volume below S2, S1 junction. And with this, you will have no relapse here, and you will avoid in this area the irradiation of the small bowel, which is the main reason for toxicity. Now let's come to my main point of discussion, which is, does rectal cancer shrinkage induced by preoperative radiochemotherapy increase the likelihood of anterior resection? Does this neoadjuvant treatment increase the chance of sphincter saving? And during 30 years, I have said at the same place, yes. And in fact, you will see that I was wrong as often. And for that, you look at the randomized trial. There was a good paper from Bushko who already said, looking at the randomized trial, we see no difference. And I made the same critical review of all the trials. And you see that at all the trial, URTC, Uppsala, Manchester, Swedish, Lyon, Dutch, Coop, all the trial, and when you look at sphincter saving, you see that none of this trial comparing random neoadjuvant treatment to a better neoadjuvant treatment has increased the chance of sphincter preservation. Even if you look into the detail to this KO, you have a small one, but it is not really significant when you go into detail, except one. I will go on this trial further on. And if you look at the figure, FFCD, ORTC, 50%, 50%, control experimental sphincter saving rate, but there is an increase. And in fact, over the past decades, conservative surgery has increased, but it is due to the surgeon. It is because the surgeon has improved their technique with the very low colonal anastomosis, intersphincteric resection, and the concept with the 1 centimeter margin rules, and not at all or very little influence of the neoadjuvant treatment. So the question, do we increase the chance of sphincter saving with neoadjuvant therapy? I think that we must admit that the answer is no. And the question is why? And this is my hypothesis that I made some 6 years ago. The hypothesis is you have a tumor like this, a T3 tumor very close to the anal verge. The surgeon feels it with his finger, you give a neoadjuvant treatment, and you achieve a partial response. The surgeon still feels it, and the surgeon will not change his decision and technical attitude. But if you have a complete clinical response, and the surgeon does not feel anything or nearly nothing, then maybe at that time, when you achieve clinical complete response, because the surgeon looks with the rectoscope, feels with his finger, at that time maybe he will change from an APR to an anterior resection. So the hypothesis is concurrent radiochemotherapy does not increase sphincter preservation because clinical tumor response with this treatment is not large enough to modify the surgical decision. What is clinical complete response? In 1974, my mentor Papillon was with the surgeon Turnbull from the United States. This was the contact therapy machine, as was here, and he was trying to see what was a clinical complete response. And this is a clinical complete response. You see Papillon performing himself the rigid rectoscopy, looking at the tumor, a small T1, introducing the contact therapy machine, this tube here. You give 35 gray, 35, not 2, 35 in 3 minutes, and 1 week later, you have a tumor shrinkage, you give another 30 gray with this contact therapy machine, and you have a complete clinical response. You see nothing, you feel nothing, the rectal wall and the mucosa is supple. This is a clinical complete response. We have seen that in Lyon for more than 30, 40 years. And in a paper, I made the definition, complete clinical response is defined, total disappearance of tumor, normal supple mucosa and rectal upon digital and proctoscopic examination. And in the last Accord 12 trial, which was published recently with a local relapse 4% and 1% toxicity, We ask all the surgeons to make an examination to assess this clinical complete response after 50 gray, kept 50. Clinical complete response, partial response, stable progression, surgeon before surgery. Out of these 600 patients, 470 had this examination. Only 5%, 24, had a clinical complete response. It is not so frequent. It is why this neoadjuvant treatment does not modify. Partial response, stable progression. More clinical complete response with 50 gray than with 45 gray, but no difference significant in sphincter preservation. If you look at sterilization rate in this trial, complete response, 50% of sterilization rate. Partial response, only 18%. If you look at conservative surgery, clinical complete response, 87. Progression, 47. All patients with a clinical complete response in this trial had a negative circumferential rectal margin. And 2 of them had only local excision or 1 with watch and wait, called like that by Angelita Bergama. Of course, 3-year disease-free survival, it is better to have a complete response, 92, than a partial response, highly significant. So the message is, clinical complete response with your finger and your eyes is a key endpoint in rectal cancer after neoadjuvant treatment. It is predictive of sterilization, it is prognostic of the survival, and it can individualize the treatment and help the surgeon to go to conservative surgery. So, can we increase this clinical complete response? I will not go into detail, but medical treatments so far are not able to really increase the clinical complete response. You can increase this complete response in 2 ways. Increase the interval between the end of the neoadjuvant treatment and the surgery, and most of it by increasing safely, this is very important, safely, the dose of radiotherapy. And here again, randomized trial. In Lyon, we made in 1999 because the surgeon was discussing, I like to operate immediately after the radiotherapy because it is nice to dissect, there is some edema. No, I like to operate later on because there is tumor shrinkage. And we say, well, just compare. Immediate surgery, 2 weeks after, long interval, 6 weeks. Sterilization rate, 4%, 11% significant. And in the very low rectal tumor, less than 6 centimeters from the anal verge, 23% sphincter saving, 41%, borderline significance. And at 15 years, no difference. So when you delay the surgery, you have no detrimental effect on the overall survival. The second way is to increase safely the dose using this X-ray brachytherapy, so-called contact therapy. And here, there is a randomized trial. A few words of what is X-ray brachytherapy, the papillon technique. You have the proctoscope, you see the tumor, and you shoot the tumor directly with the 50 kV. With the new machine, you can see the 50 kV on the monitor and the tumor. You have different kind of proctoscope according to the shrinkage. It is what you call adaptive radiotherapy, guided by vision. You have a special table, the tube. The patient go on the table, and you shoot directly the tumor. So this technique was developed since a long time ago, and this is a T1 tumor. After 35 gray, 1 week, another on day 21. Most of the time when you treat small T1, you have a complete disappearance, and of course, some years later, you can have some telangiectasia and some mild bleeding. Results, T1, some small T2, maybe 90% local control, 81% published in many journals. So as you see, this contact therapy, X-ray brachy 50 kV, is a very unique radiotherapy with a high precision under high control for accessible tumor. You can deliver safely high dose tumor, and you spare completely, of course, the normal mucosa. But what we want to treat is T2, T3. So you have to combine X-ray brachy 50 kV with external beam to control the primary. And it was clearly said that if we want to do organ preservation, we must control the lymph nodes, not on the primary. And for that, you start with X-ray brachy, then you add the external beam therapy, and after that, if you have a complete response, you can do watch and wait, you can do local excision, or you can boost sometimes very low tumor with interstitial brachytherapy. A T3 ulceration proven by the ultrasound, which is in the white part, which is the fat, after contact therapy of external beam therapy. Another case, just in front of the vagina in a woman, this tumor is a T3, and you have the result combining contact therapy and external beam therapy. Experience between Lyon and Nice, patient 81, 72, 42, 53, 83 local control, survival rate 43. Most of all, which is important, when you combine this and you are treating patient with no obvious positive lymphatic spread, there is no lymphatic failure. This is very important. Can we prove it? Yes, we try to make a randomized trial, which was published in JCO in 2004. You take T2 and T3, less than half a circumference. Circumference extension is very important. Low rectal tumors. External beam radiotherapy versus the same plus 90 gray in 3 fractions of contact therapy. Endpoint, sphincter saving procedure. You remember that we reached 40% in the previous trial of interval delay, and we wanted to achieve 70%. We need 88 patients. And this was the only trial which was, in my experience, successful with my hypothesis. We had 43 patients, 48 patients, mostly small T3, clinical complete response only 2% with external beam, but 29% with the contact therapy. And at the end, sphincter preservation 40%, 76%. It is significant. And out of these 34 patients, 10 of these 44 were able to preserve their rectum, either with watch and wait or either after local excision. And now we have published recently in the Red Journal the result at 10 years. At 10 years, 29% colostomy-free with external beam alone, 61% highly significant with the addition of the boost with X-ray brachytherapy, and no difference in local recurrence, no difference in overall survival, and 9 patients are still preserving their whole rectum with a normal bowel function. 1999, this patient came with a T2. She was randomized. The tumor is here, very close to the anal canal, and she had the contact therapy, complete response, and the surgeon agreed to change from amputation to local excision. And this is the local excision, this is the residual ulceration, this is the anal canal squamous epithelium, and this is some mucoid flax showing that the tumor was really in the musculare propria, and 12 years after, this patient has completely forgotten she had a rectal cancer. She has preserved her rectum. So in lower rectum, this preoperative treatment, safe dose escalation with X-ray brachytherapy can increase clinical complete response and give sphincter preservation and increase organ preservation. So this was my paper, and I think that this hypothesis is coming to be true. So rectal cancer treatment, the standard treatment is neoadjuvant chemotherapy and radical surgery. When to try to achieve this complete clinical response, to achieve organ preservation. In 2 situations, in T2, small T2 less than 4 centimeters, and there is a work from Julio Aguilar in United States at any age, or in elderly frail patient with T2 or small T3A. In T2A, radical surgery is the standard. There is no problem. We can try. This is clinical research. This chemoradiotherapy and XRB, and then transanal or watch and wait attitude. This is a patient referred to me by a surgeon. I've seen this patient. It is a T2. And he said, I know that you can control. The patient was operable. I gave the contact with the papillon machine, complete response, and you see, 3 years later, this patient is alive, but with metastasis. You remember, T2, 81% local control, no lymph node failure. And we have a trial now in a group called ICON with the French, the UK, which are now the leader, the Danish. We take T1 more than 2, T2 less than 4, and 0, of course. We start with X-ray 90 grains refraction, cap 50. We expect 90% of clinical complete response. And if it is like this, observation or local excision, depending on how the surgeon wants to achieve, and we want to achieve less than 10% of local relapse. Of course, if there is no response, TME. Elderly patient, it is well known that in elderly patient, the mortality is quite high, above 85. There is some leakage or incontinence, and the conclusion of the surgeon is we should achieve less invasive treatment and maybe contact therapy, high dose in the tumor, low dose to normal tissue. Another example, treated in Nice, 84, cardiac insufficiency. You have the tumor, you have here the perirectal fat, it is a T3. Look how the ultrasound is close and matching the endoscopic view of the patient. Contact therapy, 100 gray, cap 50, patient okay, and absolutely no symptoms, well preserved. 23 patient, more than 80 years, contact an external beam, 19 only radiotherapy, 4 local excision, T2, most of them control, T3, most of them. Nearly none of them died from their rectal cancer. My gold medal, 94 years of age, the first case I saw melanoma of the rectum, a blue tumor. It was early January. I started with 18 gray. I referred the patient to one of my colleagues. And to my surprise, after 6 gray refraction, the patient come back and the tumor was still there, but it was in better condition. And I gave X-ray brachytherapy. In November 2008, the tumor was still there. You can see how slow the reduction can be. And in June 2009, there was no more tumor, just the bluish color. And this patient is still living, and I hope to celebrate 100 years next year in 2014. And this is a contempt-free trial for elderly patient in T2, T3, XRB and external, or start with external and give XRB. This is a place where now most of these patients are treated. It is Dr. Sunmint in Clatterbridge, close to Liverpool. There is a special training for this contact X-ray or X-ray brachytherapy. The next one will be in October this year. This is the treatment is achieved, a tumor. This is 3 centimeter. This is 2.5 centimeter ulceration. This is a T2, maybe a T3. And he treats with contact and external beam. He has treated more than 350 patients, and he has the same result as I presented. So what is the evidence at the present time? Surgery is the main treatment. We should perform TME. Neoadjuvant treatment. We have seen from randomized trial that it improves local control, even with a good TME. It does not change so much the chance of sphincter preservation, except if we achieve clinical complete response, we can do organ preservation with accessible toxicity if we irradiate small volume to avoid toxicity. Ongoing field of research, sphincter saving, mainly organ saving. In T2, T3, preoperative XRB and chemoradiotherapy to achieve CCR, because this is the philosophy, radiotherapy, high dose but small volume. And which tumor? And here I am back to what Dr. Weber said a few minutes ago. It is a clinical approach, and this is maybe the most important picture. This is a tumor. This is the same tumor. This is the same tumor. This is the same tumor. All these 4 tumors treated in Nice or Lyon, in São Paulo, in England, or in Maastricht achieve clinical complete response. This is what we must find with our finger and with our eyes doing the rectoscopy. It is this T2 or very small T3, and this is one we can achieve clinical complete response. So the conclusion is clinical approach is very important. This is Lars Pallman calling the digital examination the bioprobes. I'm sure that all the surgeons agree that for them it is a crucial examination. We should all use this very simple rectoscope to distinguish a T1 from a T3 in the niches position and a complete clinical response. This is my conclusion. Clinical practice, rigid proctoscopy by the surgeon, by the oncologist, to achieve clinical outcome and to be able to save rectum. I thank you for your attention.
Thank you very much, Dr. Girard, for the comprehensive review of the topic. We finishing late, and we make short period of question. Any questions in the audience? Or can you invite the speakers to the stage?
The second question is, for gastric cancer surgery in the US and in Japan, you do go for D2 level. Why the mortality or the survival is different from here and there? This is number one. And I don't know if Dr. Sano, if you have, or our colleagues from the US, do you have experience of the Asian patients in the States? Do they have the same, survival, or those with gastric surgery being treated in the States? I don't know if you have an answer or any study came to that point or not.
So for the neuroendocrine tumor, what we think in the States is that there is more awareness, therefore people are looking more, keeping that in mind in their differential diagnosis when they see a patient with some symptoms. Also with the increased use of cross-sectional imaging, people are picked up with silent disease, could be liver metastases or abdominal mass. And the third thing is that we believe that there are some environmental exposures that we cannot identify. So these are the reasons why we think there is an increase. More awareness, more education, information, communication to look for them. Nowadays we have patients calling us to say, well, I have symptoms, I think I have carcinoid, can you see me? And also obviously the more we're doing the scans on patients and picking up more stuff.
Okay.
As for operative, you say operative mortality after D2.
Yes.
Correct?
Yes.
Mortality, in Japan it's now, a nationwide registry says it's less than 1% after D2 gastrectomy, because we carefully choose the patients and the patients are very fit. This is the most important point. And even for Japanese experienced surgeons, large fat patients with heart disease, these are very difficult. But operative technique will not regenerate. It's simply replaced by the scar tissues, correct? So if so, then the resection margin is always the same, simply the very close to the active tumor or simply close to the scar tissue. So anyway, the resection line is similar. Then why can you preserve the sphincter? I always think that it's strange. Professor, he left. Okay. So the drawing, the tumor shrink. Your drawings was very, well done. But what happened in the submucosal or muscle layers after shrinkage?
Well, I think it's not just replacing the tumor superficially by the mucosa which will cover the tumor, which will remain the same behind. Because you have seen that you have, in average, close to 20% of complete sterilization.
Yes.
So in that case, there is no more tumor.
Yes.
When you take T2 with only 50 gray, you have 50% of complete sterilization. Mm-hmm. With clinical experience, when you take T2 and you combine contact therapy, 90 grains refraction, and external beam irradiation, you have 90% long-term local control. That means that if you give high dose to the primary, not only you cover the tumor, but you sterilize the tumor, and of course, small tumor. If you have a circular tumor, forget it.
Yes.
If you have a tumor more than half of the circumference, forget it. If you have a T2 or a T3A, superficial T3, just starting to invade the perirectal fat, and if you are able to give a very high dose with chemo in a very small volume, not to have toxicity on the rectum, you can achieve complete sterilization. Then the question is, should we do like Haber-Gamma? Should we do wait and see? Or should we do like, for example, the surgeon in New York, Ruggiero Garcia Aguilar, local excision, elective local excision? This is another question. I have nothing against local excision, and I have some patients treated with local excision. The question is that when you do local excision, and if by bad chance you find R1 resection, you have to reoperate, and then to reoperate after a local excision, sometimes I heard from the surgeon it is not so easy. So local excision or wait and see. There is a randomized trial by a surgeon called Lezoque.
Yeah,
from
so
Roma.
surgeons have impression that, oh, I can cut, or I cannot. So abdominal perineal resection or sphincter preserving resection. The surgeon's impression, but the exact line, the tumor, even if the tumor shrunk, probably it is simply replaced by the scar tissue. No normal tissue will grow.
Complete or nearly complete sterilization. If it's just small shrinkage, don't change your surgery.
Okay.
Maybe I just add to that, because we do for big tumors. I know I want to ask him a question later, but just answer that question, because we do more, I think, as rectal surgeons than gastric surgeons, radiotherapy. And really, we are looking, first of all, because it's a very tight space in the pelvis, and in fat males with narrow pelvis, it's quite difficult. So we are trying to string the tumor so we get more space to work. Basically, that's one thing. And these patients, we are trying to sterilize the outside field. So not necessarily we need to get good replacement. In fact, often when we wait after the 4 to 6 weeks, you find that there's a lot of tumor replacement by fibrous tissue. So you don't actually have very healthy normal tissue, but it's enough that we can sterilize that field and so that you can do anastomosis. But just a question for you, Professor Gerard. You are saying that if the tumor is large and fixed, that's the indication that most of us actually use preoperative chemoradiation to try and sterilize the field and try and string the tumor. But according to your lecture, those tumors, you say forget it, because they don't usually work. We find that they actually increase the difficulty in many cases, because it becomes very stiff and quite difficult to operate. And you are saying that because we have actually seen some cases where it strings, but not many, that we can preserve the anus. But you are saying that you rather just go for the T2 or T3, and certainly not more than half circumferential, right, for preoperative chemoradiation to try and string tumor. That's one question. The other question is,
what was the question there? Big tumor.
Big tumors is the one that we are using a lot of preoperative chemoirradiation to try and string the tumor. But your opinion is that it's not that useful.
But my opinion is that you give this pre-op radiochemotherapy not only to shrink the tumor, but mainly to prevent local relapse after a good surgery.
Yes.
But you don't expect to increase the chance of sphincter preservation. I've shown that when you have a large tumor, even if the tumor shrinks, you will do the same surgery.
Yes.
If it is close to the anal canal, you will do the APR. If it is a bit, you will do the anterior resection, either coloanal or intersphincteric, but you will preserve.
Yes. The other question I have is actually because we have been routinely taking out the rectum even after complete shrinkage. And in some of these cases, macroscopically there's shrinkage, but microscopically there'll be lymph nodes still showing tumor cells, or muscular or serosa still showing nests of tumor cells. Now this is what we don't know, whether these tumor cells are viable or not. We actually haven't had enough follow-up to see whether they are viable or not if left behind. We haven't actually left any behind, but I'm just a bit curious about the data from the rest of the world, because we know that after chemo irradiation especially, recurrence tends to be much later. I mean, we know that 85-95% of tumors that recur within the first 3 years, but following radiotherapy and chemotherapy, we have seen patients recurring after 7, 8, 9 years. So it may just be that this period is prolonged, so we're not seeing them yet. I just want your opinion on that as well.
Well, just some comments. If you have any residual lesion, feeling with your finger some induration or seeing a tumor, of course, you will do TME surgery. And if you need to do an APR, you will do an APR. The question is, if you see nothing, if you feel nothing, can you rely on this clinical evaluation? Of course, you can add a new MRI, you can make diffusion MRI, you can do PET-CT, but all these examinations will not tell you if there is not a small foci in the rectal wall. And then you have the choice between doing the surgery as you want, but maybe not an APR, maybe an anterior resection, if you have a complete clinical response, or watch and wait as Abergama is proposing. But if you select a small tumor, maybe you can be in a more safe attitude to the local excision to be sure that it is sterilized. So this is field of clinical research. And conservative treatment can be selected only for tumor less than half circumference and less than 4 centimeters. It is why it is so important that the surgeon measure the tumor himself, feel the tumor, and check the tumor after the neoadjuvant treatment by routine rectoscopy.
Probably your question more of a biological kind of cells. We know biologically rapidly growing cells, they respond rapidly and they recur rapidly. So when you attack chemoradiation, you are killing these cells. But the cells which are recurring late, they're actually slow growing, low growth fractions. So, and they're not affected by chemoradiation, and they are recurring after 8 or 9 years. Might be some research where how you can attack these cells.
Yes.
Any other questions? So we can close our session. Thank you for the attendance and for the speakers. And we'll be seeing you tomorrow.
Was simply replaced by the Scottish.